Alexandra Palladina is going to talk about principles of MRD monitoring in AML.
Dear colleagues, I am very grateful to organizers for the opportunity to stay in this way in front of you, and I'm glad to present this report, which will highlight the modern approaches to MRD detection in AML, and also presents our own data. Acute myeloid leukemia, as we know, is a heterogeneous group of neoplastic clonal diseases of hematopoietic tissue, which is characterized by block of differentiation of myeloid progenitors. Acute myeloid leukemia in childhood is one of the most complex diseases, which to date we know more than 20 variants of acute myeloid leukemia with different prognostic factors. But in general, acute myeloid leukemia in childhood is much less common than acute lymphoblastic leukemia and accounts to 15 to 20% of all acute leukemias of childhood. And this, combined with heterogeneity of disease, makes a search for diagnostic and therapeutic agents more complex. It's important to note that significant progress has been made in treatment of acute myeloid leukemia, and this is not only due to new therapeutic regimens and due to improvement of supportive care, but also due to individualization of therapy depending on the risk groups. To date, failure to achieve remission after the first course of induction treatment remains a powerful factor of poor prognosis, even if complete remission is achieved by subsequent treatment. At the same time, 20 to 41% of patients who are younger than 18 years old, even if they if these patients achieved remission after the first induction course, they can subsequently relapse. Currently, we have methods such as flow cytometry, which can make it possible to detect one malignant cell per 10,000 or more melanocytes. Such in-depth studies are absolutely necessary since it has been proven that presence of MRD and MRD status positive is a powerful predictor of relapse. We know now we know that in acute myeloid leukemia, the criteria for flow cytometric MRD status has only recently been introduced into recommendations. The determination of MRD status in AML is quite difficult and more difficult than in acute lymphoblastic leukemia and in even B-cell chronic lymphocytic leukemia due to high heterogeneity of immunological characteristics of blast cells in AML. The assessment of MRD in AML can be based on one of the principles. The one is searching for cells with individual leukemia-associated immunophenotype corresponding to that in the diagnosis. The second is the different from normal method, or counting all immunologically different myeloid cells. The application of the first principle needs a thorough, detailed study of the tumor immunophenotype at the onset of disease. Its limitation is the phenomenon of immunological shift. According to some studies, the immunophenotype of AML in relapse is often not the same as it was in diagnosis. Thus, it can be assumed that the assessment of MRD using the first method is more applicable at the early stages of treatment of acute myeloid leukemia. The limitation of the second method, different from normal method, is the possibility of the appearance of small populations of myeloid cells with aberrant immunophenotype in the bone marrow. During stress, normal differentiation, antigen expression can change without implying the presence of disease. It may be associated with cytostatic therapy, with targeted therapy, as well as with use of colony-stimulating factors. These makes it difficult to distinguish spontaneously occurring abnormalities of the myeloblast immunophenotype from those characterizing the actual tumor population. To date, universal applicable panels of monoclonal antibodies are still being upgraded and investigated. Marker combination defining a Leukoz-associated immunophenotype may have different frequencies in normal bone marrow, and consequently have different specificity in MRD detection. Thus, approaches to the detection of MRD and AML are constantly being improved. Tumor cells in AML differ from normal myeloid progenitors. These differences can be detected using flow cytometry when we look for signs of aberrant immunophenotype. This includes co-expression of antigens that are not characteristic of myeloid line differentiation, for example, CD56 on myeloid line blasts. The second type of aberration is the expression on myeloid progenitors, the markers of mature granulocytes, such as CD11b and CD15, 16. It's also a sign of aberration. And the next type of aberration is the change in the intensity of expression of myeloid lineage antigens, such as very low expression or too high expression for normal myeloblasts. In our work, minimal residual disease was analyzed in 28 children with AML. The group included 12 boys and 16 girls aged 5 months to 17 years, median age 5 years, who received treatment for newly diagnosed acute myeloid leukemia in period of 2014 to 2021, according to protocol NEDOG AML 2012. In all patients of group at the time of determining the MRD, bone marrow remission was achieved. In most patients of the group, the level of MRD was assessed before the start of the second course of chemotherapy, and in 5 patients, MRD was assessed at a later date. When determining the minimal residual disease, the panel of antibodies was compiled individually for each case according to primary immunophenotype of patients' blast cells. In each case, aberrations or features of the immunophenotype were noted, which made it possible to distinguish between normal myeloid precursors and tumor ones. 2 million events were analyzed each time. By sequential gating, a population of cells with immunological aberration corresponding to that in the primary study was isolated. The assessment of MRD status at the work was carried out relative to the value of 0.1% of myelokaryocytes, which corresponds to strategy of most research groups. At diagnosis, all patients underwent detailed immunophenotyping, and in the last 8 years, diagnostic approaches have been based on the 8-color concept of Euroflow, which includes assessment of linearity of leukemia by a lot orientation tube, and then followed by analysis of blast cells according to their lineage. The tubes allow to characterize neutrophilic, monocytic, erythroid, basophilic, megakaryoblast antigens, also aberration of co-expression of lymphoid markers, and antigens of blastic plasmacytoid dendritic cell neoplasm. Let me introduce an example of MRD detection. This is patient M, acute myeloid leukemia with minimal differentiation, and on diagnostic immunophenotyping, we see that myeloperoxidase was absent on blasts, which confirmed the date of cytochemistry, and the feature of case was co-expression of CD7. And when assessing the MRD at the end of the first course of treatment, we saw only 0.8% of blasts in a morphology study of bone marrow. During flow cytometry, nucleated cells are highlighted in blue among singlet events. in red, and the gate of CD117 positive cells is highlighted in green, and the clearly visible population is aberrant, CD117 positive, CD7 positive, and the MRD status of this patient was positive. Sorry. And we evaluated the relationship of MRD with the relapse-free survival of patients with AML. We assessed the relationship between MRD levels greater than and less than 0.1% and relapse-free survival among those patients who had the level of MRD determined simultaneously with first bone marrow remission. Number of patients of such patients was 23. Allogenic transplantation was performed in 6 patients of the group due to unfavorable prognosis factors. In each of these patients, the level of MRD during the first remission was more than 0.1. It's interesting to note that the initial stages of the work, we evaluated 5 patients for the presence of MRD at a later date after the start of treatment. The evaluation was carried out during the period of bone marrow remission. 2 of these patients were MRD positive. It's clear that after the end of induction therapy in these patients, the MRD status was positive too. Evaluation of survival for the entire group of patients showed interesting results that patients with MRD presence had lower disease-free survival rates. Log rank was 0.09. The next slides are devoted to MRD in blastic plasmacytoid dendritic cell neoplasm. Blastic plasmacytoid dendritic cell neoplasm is an extremely rare disease with an aggressive course. The extremely rare occurrence and controversial biological nature of such tumor makes it difficult to diagnose, treat, and to assess the effect of therapy. Plasmacytoid dendritic cells are part of innate immune response as they secrete type 1 interferon. There are several fractions of plasmacytoid dendritic cells in normal bone marrow. We have CD56 positive and CD56 negative fractions of plasmacytoid dendritic cells. PDC fraction of CD123 positive, CD4 positive, CD56 positive is a non-tumor analog in blastic plasmacytoid dendritic cell neoplasm. Normally, the ratio of CD56 positive to CD56 negative plasmacytoid dendritic cells is 0.12. So, the fraction of CD56 negative plasmacytoid dendritic cells is much larger. In the following case, in diagnostic flow cytometric study of bone marrow, the tumor cells expressed CD123, CD4, CD56, CD43. The expression of CD45 was low, and there were absent the progenitor cell markers, B cell and myeloid lineage cell markers. At the end of the treatment stages, MRD was determined by flow cytometry. Isolation of 56 positive plasmacytoid dendritic cells was carried out on basis of light scatter parameters, nucleotropic dye, CITA 41, weak expression of 45, and co-expression of certain antigens of CD4, CD123, and CD56. In the described case, the dynamics of the ratio between CD56 positive and CD56 negative plasmacytoid dendritic cells showed an increase in the CD56 positive plasmacytoid dendritic cells just before the relapse of the disease. This change of the ratio, the red line, became noticeable in the analysis of hypercellular bone marrow in the absence of increased number of blasts, green line, and in the absence of proportion of CD56 positive plasmacytoid dendritic cells among myelokaryocytes. It was 0.06. So what we had was the increase in ratio between 56 positive to 56 negative plasmacytoid dendritic cells. It increased from 0.06 to 8.9. 1 month later, the relative content of CD56 positive cells was 81% of plasmacytoid dendritic cells, while in morphology study, the increase of blast cells, there was an increase to 5%. And 1 more month later, blast cells numbered already 85% on bone marrow punctate. So what we can conclude? What we can conclude is that, as it was said before, it's important to monitor the dynamics of tumor burden, and in case of blastic plasmacytoid dendritic cell neoplasm, dynamics of PDC fractions ratio. Basing the assessment of minimal residual disease and acute myeloid leukemia in children on the characteristics of primary immunophenotype of blast cells can be effective and allows diagnosing a less favorable prognosis for the disease. Thank you for your attention.
This is CD123. Is it a hairy cell marker?
What?
Is the CD123, is it present on hairy cells?
On hairy cells, yes. If it is hairy cell leukemia, we usually see CD123 marker, but in variant type of hairy cell leukemia, it can be absent.
Yeah. Any more comments? Are you routinely using this for all AML patients in your institute?
Yes, we usually try to assess the MRD level on the date before the start of second chemotherapy course. And we still get more investigations about it and try to get more results to show you.
Very nice. So the discussion continues during the coffee break, isn't it?
Yes, yes. So now it's a coffee break.
Thank you.
Okay.